Disclaimer, welcome to Triage.RN. This podcast is for general education, entertainment, and discussion purposes only. All patients and scenarios are fictional, hypothetical, and generated using artificial intelligence. No real patient information is used. This podcast is not medical, nursing, clinical, legal, regulatory, employment, or personal advice, and it does not establish a standard of care or create a professional relationship. Do not use this content to diagnose, treat, triage, or make clinical, legal, or personal decisions. Always follow your local laws, professional standards, employee policies, and current clinical guidelines. Consult your own healthcare provider, lawyer, licensing body, employer, or professional liability insurer when appropriate. In an emergency, contact your local emergency services.
Red, yellow, green, where do you go? Time is louder than you know. Step by step through the double doors, we decide what matters more. This is Triage.RN.
Welcome. This is Triage.RN. I am your host, Anthony. This is episode number 1. We are the pilot episode here today. I've created this podcast from the ground up. It's something I've thought about for a very long time now. I've been trying to make this for about, maybe like 2 months now, but I've been thinking about it for maybe a good 6 months. It's been a lot of work, to be honest with you. We have created this studio, this setup, and we're ready. We're ready to fire off this first episode. Now, let's start this off with a little bit about me. I am Anthony. I am your host. I have been an emergency room nurse for 10 years now. 10 years. Wow. When you think about that, it's like, oh boy, I feel old. I mean, it's crazy because you hear of these nurses that have just been, in the same discipline for 25 plus years. And I think to myself, how in the hell did they get there? But I mean, 10 years has flown by now, a full decade. Oh man, every time I say that to someone, I'm just like, this is absurd. Anywho, we're going to get into it here now. That is me in a nutshell, to be honest with you. Now, I have created this podcast to create a safe space for nursing. I have heard a lot of podcasts about physicians, paramedics, all and above healthcare workers, but really, I've never truly found a safe space for nurses to come together and discuss nursing-related topics. And that's why I wanted to create this podcast. I wanted to create a safe space for people to come together, comment, share, discuss difficult situations in broad spectrum, or maybe, this difficult patient or scenario without using specifics as to what to do in the future, maybe next time. I think this podcast is a space for nurses to really relate to one another through the hardship, the hard times, the emotional times, the positive times, the great times, the accomplishments, all the above. I think that's what this space is for. Now, in doing so, we have to be cautious because we are nurses. We are a public figure. We have to understand that we cannot share specifics about patients. We have to have these disclaimers, as you can see here on my far left and on my far right. We have disclaimers everywhere saying, that none of this things said on this podcast, whether it's myself that has said it, a co-host that has said it, or a visitor that has said it, is medical advice, okay? These are only discussion purposes, and whatever you hear here, you need to bring back to your unit and fact check that first. You need to do your own research and your own due diligence to be able to practice what we're saying here, okay? So take that as what it is. Now, that being said, I think that moving forward, I want to just be open and honest with people that this is how the podcast is going to work, and this is how the layout's going to work. This is what I intend for the podcast. So for now, I want to let you know how it kind of goes. And every episode that we have, I want to have this portion at the beginning of the podcast where I'm fact-checked. I want you guys to write in, to comment, to to share, to message, whatever it may be, but I want to be fact checked. I've been doing this for 10 years and I am no expert. I will be the first one to tell you that I know 10% of what happens in emergency departments, and that's after being there for a decade. Now, that's not there to scare you. It's there to be humbling. It's there to be like, this is something, an employment, a career that you're going to learn something new absolutely every day. It may not be from patients, it may not be from employers, but I can assure you, every set I have, I am learning something new. And that's what I love about an emergency room nursing. It is new. It is fast-paced. You learn. It's always challenging. Whether you're having ethical dilemmas, whether you're having, I don't know, it could be anything. It could be a problem with another nurse. It could be a problem with a patient. It could be anything. Emergency room nurses, they are the ones who go through it the most, I think. Now, I am not taking away from the med surge, the plastics and burns, the medicine, the surgery, the ortho, all the above. I want you guys here as well, because I think that this podcast is going to speak broad terms to everyone. I think that you're going to be able to relate on your cardiology unit. You're going to be able to relate on your ortho unit. I think you're going to be able to relate anywhere, because what we're going to talk about here is going to be so universally used in every unit that you work on. Now, jumping back, I want to be able to be fact checked. So I want you guys to write in at the beginning of every episode. We're going to have this little portion where I say, hey, I screwed up. I don't know everything. This is what we're here for. We're here to learn. You know, maybe I said something wrong, or maybe I said something that you do differently somewhere else. That's what this is about. I want to be here to encourage people to learn. It's okay to be wrong. It's okay to say, you know what? I'm not the best about this topic. And that's okay. That's what this is all about. So at the beginning of every episode, we're going to kind of do a little fact check. And then moving on, we're going to have either a co-host or it'll be me discussing a certain topic. And then at the end, we will discuss a triage. And that's what this whole episode, these episodes are going to be about. The core, the meat, the foundation of this is that first person that walks in through the door, that triage that you're expecting from this patient. And we may get into, you know, their progression through the hospital and their stay and how that's going to look and those kind of things. But the core and meat of this is going to be the triages, the weird and wonderful, the absolutely absurd triages. Now, because of patient confidentiality reasons, we may not be able to pull real triages. So every triage that you're going to see on this episode is going to be AI generated. However, I have made it so that the AI is producing realistic like triages, something you may see, something you may relate to, and that way it's as real as we can get it without breaking that confidentiality with that patient-nurse relationship. So just be aware of that. Now, that being said, I think what we're going to do here today is jump right into it. We're going to just go right to a straight triage. We're going to discuss it, and we're going to go from there. So let me just pull this up right quick. Let's talk about this very first triage on the very first pilot episode here on Triage.RN. Now, this triage is going to be something you see every day. Something when you get to work and you're like, hey, I've seen this patient before. I know what to expect. I know what this patient looks like. And it's just to relate. This is the first one. We're going to make it easy. And then we're going to go to the difficult ones later on in other episodes. But today I wanted to keep it simple, straightforward, and just chat about a couple things. So this patient, I'm going to set the scene for you as well. So this patient's going to walk in. They're walking through the doors. And in triage, it is very advantageous of you to be aware of everything that's going on around you. So when you have someone in front of you, You're not only looking at the patient in front of you, you're looking at that person that's coming through the door. You're looking at the person to the left of them. You're looking to the person to the right of them. You are looking at everything. You are on alert 100% of the time. And when you see this person, you know right away what this person is. Okay. So this person walks in. They're walking in a little disheveled looking. Maybe like they're a little unkept. They're not sleeping well. And that shows when they walk through the door. Okay. They walk through the door. They're lined up for your triage. And they're the only ones sitting there. So you're going to take them next in your triage. This person walks in. He sits down. We're going to call him he. We don't know his name. I don't know if it's a he or she, but we're going to call him he for now. He walks down and he says, where do I start? Immediately, I'm thinking, this is going to be a long triage. Immediately, I know in my head that this person is here for a non-acute issue because they're saying, where do I start? And that's okay. I'm okay to like maybe stereotype a little bit in this situation because I'm not looking down upon the person or anything like that. I'm just realizing that this person is either sick or not sick. That is my goal in triage, right? I want to understand if this person is sick versus not sick. And right away, I am seeing chronic. I am seeing chronic through the front door. So they sit down, they say, where do I start? And I say, well, what can I do for you today? And they say, well, you know, back about a year ago, I got COVID. I got COVID and it's kind of been downhill ever since then. Now, we all know these COVID patients. They have been hit hard, okay? Especially these long-term COVID patients, they have gone through the most. So I feel for this guy already. I'm feeling for him. I know that this guy's probably been struggling. And he goes, you know what? I've been going through this for a while now, ever since I got COVID. I've been not sleeping, not eating. I've been having some stomach pain on and off, some nausea, vomiting on and off. I have been just general malaise for a while. Maybe this cough that comes and goes. And he lists maybe 14 issues, okay? And I'm just pulling 14 out of nowhere, out of thin air. And in triage, our goal here is to create a category for this person. Are they sick versus not sick? What are they here for? And the struggle, especially if you're new to triage, the struggle going through someone that has multiple complaints like this is trying to come up with one complaint in particular that you have to put for a category, especially when you're doing CTAS. Now, with this person in particular, I'm going to have to try to break through that list of complaints and try to find one of them. And the way I express that is I need to get through this bullshit, right? So there's a lot of things I don't care about. There's a lot of things I care about. And you know what? I don't want to say I don't care about them. I just want to say that there are things that are more minor and there are things that are more major, okay? So there are things that I need to exclude and there are things that I need to include, okay? There is no way I can write a triage with 14 complaints. It is not going to be possible. So I am going to ask him specific questions. Sir, why today? Like, why is today the day you have decided, if these 14 symptoms have been going on for a year plus, why today are you coming in to the emergency department? And it may be that, you know, he's just had enough. Maybe it's that today's the day just because it's been enough. Or maybe today's the day that, you know what? Today's the day because this abdominal pain, I can't live with it anymore. It's been ongoing for some time, causing me some nausea. I haven't been eating well, and I just can't get over that. There's nothing I can do at home, and I just can't get over it. So at this point, I need to create a category for this person, right? And maybe I don't do the category at first. I can do the category later. So I'm going to start writing a story out, right? So I'm going to put ongoing complaints for 1+ year ever since he got COVID. And this is all going to go into my subjective category. I'm going to put, hey, subjective. This is going to be what I'm seeing and hearing. This is what I'm going to be. This is the story, right? The subjective is the story that you're hearing from the patient. Rather than the objective, you're going to put what you're seeing, what you're feeling, what you're assessing from the patient. So subjective, he's been here. He's been ongoing complaints for about a year since having COVID. He's had multiple issues related to this. And maybe I'll list some of his symptoms. The abdominal pain, the nausea, vomiting, not eating, not sleeping. And I'll list a few of them for sure. The ones of importance. Maybe I'm listing all of them because I think they're all relevant. Maybe that's it. I'm going to continue on to his story. And he just says that today he can't take it anymore and he needs to get assessed by a doctor. Subjective. That's it right there. I have a time. I have his complaint. I have the story leading up to the complaint. And I have why he presents here today. That's what I'm looking for in my subjective. The objective portion is going to be more like what you're seeing, what you're feeling, and what you're assessing. So this may be patient walked in himself, looks slightly disheveled, looks fatigued. I'm going to probably push on his stomach. I'm going to palpate his stomach to see if he's having any tenderness. Now, with a chronic issue like this, I probably am going to think I don't have any tenderness. So I'm going to put abdo, non-tender, complaining of nausea at this point, but no visual vomiting. And it might just be as simple as that, right? Maybe I am just feeling his pulses when I'm doing his vitals. Now, this person's vitals from this triage in particular, they're all normal. Blood pressure's 142/82. His heart rate is 80, right on the money. His respiratory rate is 16. His temperature is going to be 36.6, so afebrile. His oxygen saturations are going to be 98%. And his pain score is like a 1-2 based on his abdominal pain cramping that he has described here today. I've also done my ABCs on this guy. So his airway is patent. His breathing is unlabored. He walked in by himself, and that did not cause him any shortness of breath. And neurologically, he's intact. He's a GCS 15. He has no issues comprehending, talking, speaking, anything like that. He is a GCS 15. Other than that, I'm not doing any other neuro assessments on this guy because I don't feel like we need to because he is answering the questions appropriately. And I'm going to put some of that in my objective finding. My ABCs are super important. I want to make that clear pretty much in every triage. Again, with this patient, I think the struggle is going to be stopping the triage, to be honest with you. And sometimes stopping the triage can be the hardest thing possible. Especially when that patient walks in and says, "Where do I start?" This story could go on for 20-30 minutes because this person has already created this story for a year and a bit now. So you need to have an escape route from this triage. I have normal vitals. I have subjective. I have objective findings. I have a triage complaint. I have everything I need. And this person is still going on about something that happened a year ago. And I need to try to navigate this conversation in the most respectful, politeful way without losing any important information that I need to add to this triage. And boy, that can be difficult sometimes, okay? Let me tell you, that can be a struggle sometimes. And sometimes my strategy in this is a couple different things, right? So sometimes in this situation, I'm doing the vitals last. Sometimes I'm doing vitals first based on if I think they're acutely sick or not. But in this case, I'm probably going to do the vitals after I'm writing the story because they're going to be still talking to me. When I'm done doing the vitals, I'm going to say, okay, all your vitals look great today. You can go have a seat in the waiting room and we're going to be with you as soon as we can. And I think that interruption of saying your vitals look normal because you're giving them feedback about their health right now, allows you to kind of cut through the story a little bit and kind of end this conversation. Other strategies I have used to try to continue on to the next triage, we'll say, is maybe I'll get up out of my chair. I'll go get something for them. I'll say, hey, do you want some water while you wait out there? Or maybe I'm saying, hey, today for this complaint, this triage, for this level of triage, it's going to be a little while today, so bear with us, but go have a seat out there. So you're trying to do it in the most respectful way. There's different strategies to this. Maybe you're trying to relate to them and you're saying, oh my goodness, like, my so-and-so just went through this as well. We're going to get through this today, but please go have a seat and we'll be with you when we can. Just something like that to try to engage in the conversation, let them know that you're here for you, but, ultimately we have to try to move on because we need to try to cut these down to 5-minute, triages here. So that goes well. Everything goes well. Patient goes out. You're finishing off your triage because you have all the information you need, and you're on your C-test. Now, C-test for this person is going to be important because C-test is going to tell us sick versus not sick, and these are the... Oh, that was the wrong way. These are the criteria over here, right? So we have 1, 2, 3, 4, and then actually we have a 5th at the bottom as well. I typically don't put too many 5s, to be honest with you. It has to be very clear cut for me to put a 5. Let me know what you guys think about putting 5s, okay? Are 5s important when we talk about triage? Are 5s relevant? Now, my rebuttal to that is, if I'm here for a medical complaint, I probably can't put them as a 5, maybe a lot of people will say prescription refills are going to be a 5, but if I've gone without my beta blocker for a week or 2 weeks or whatever it may be, then I'm thinking, hey, maybe they're symptomatic because they don't have their prescription for this long. So they're actually here for a medical complaint, and they say, oh, I'm just here to get my prescription refill because my doctor retired or whatever it may be. And I'm thinking, well, are you feeling okay today? Like, that's a long time to go without your prescription. And they say, yeah, you know what? My heart's been kind of racing a little bit, and I think it's just because I haven't been on my pills, but that's a medical complaint. They're here because they don't feel well because they don't have access to their meds. So, like, am I putting that as a 5? Probably not. So just be realistic with your 5s, right? So 5s, just err on the side of caution. We're going to get that into later episodes, but just bear with me on the 5s. And I want to know what you think about the 5s too. Let me know. Are you using 5s a lot at your hospital? I mean, personally, I'm not, but I just want to know. Let me know what you guys are doing in your area. So C-test wise, I'm putting this guy as... I'm going to use abdominal pain because that's what he's really complained to me about the most, to be honest with you, even though he has 14 complaints here today. Maybe I'm doing general and minor complaints, but I think this abdo pain is probably going to give him a higher score, so I'm going to go abdo pain. I'm going to put abdo pain as my number 1 here, and I'm going to put them in here too on my little app here so we can kind of go through them together. So let me just pull that up right quick. So let's do the C-test. So we're going to go... adult, we're going to go abdominal pain, probably like chronic, I say, but we're going to go abdominal pain for this one. Now, respiratory distress, he's like a 16, 18, he's normal. Respiratory is normal, so I'm going to say none. His vitals are all normal, so I'm going to say normal vital signs. Is he altered in any way? Nope. So I'm going to say no to that. Is he febrile? Nope, not febrile. Central pain, acute versus chronic. Is this a chronic thing that he's been dealing with for a long time? Probably. Now, the fact that when he came in, he described it as he just can't put up with the pain anymore. He didn't say that the pain got worse, and that's why he's in today. That's not what he said. He said that this has been ongoing for some time, and I just can't put up with it anymore. It's been constant this whole time for a year and a bit. So I'm probably going to put chronic on this one, right? His pain score was only a 2 or a 3. Nothing crazy there. He has no bleeding disorder that we note. And so realistic for C-task, he probably meets a 5, to be honest with you. But again, I'm not feeling great about a 5. He's going to wait a long time for a 5. I'm probably going to upscale him to a 4, to be honest with you, only because of how he looks a little disheveled. He looks like he's tired. Like he's been struggling a little bit. His vitals are normal, yes, but I think just using his overall presence, the way he looks, I'm going to override that triage to put him as a 4. Is that a wrong thing to do? No, I don't think so. You let me know. What do you think? Is it okay for me to upscale this 5 to a 4 based on a chronic problem that's been ongoing for a year? Maybe it's chronic on acute, but he just didn't really describe it well. But I'm putting this guy as a 4 all day, every day, based on a pain modifier of his abdominal pain. Maybe I'm using general minor, though. Maybe I'm going to go the general minor route, as many multiple complaints, and that's what I'm going to do. Again, I still think he's a 4 probably in that route, too, just based on the fact on how he looks. And that's okay, I think. I think it's okay to have this discussion where there's no fine line in the sand as to what score he should be, or what score he actually is. I think we have some wiggle room as nurses in triage. Now, what I don't want to do is under triage this person. Okay, I do not want to. Let's say he came in and he was at 2 because he's a central acute chest pain. I don't want to put him as a 4 or a 3. I don't want to under triage. But in this case, and again, we're going to get into that because we're going to get into the meat of things on other episodes. But let's just be cautious. I'm going to put him as a 4 for now, and then we're going to move on. All right, that's our first triage. That is literally the first triage here on episode 1. That's an easy one. We're moving straight forward. There's a little bit of discussion there. Now, we're going to get into more complicated topics and more complicated discussions here in later episodes. Episode 1, I just wanted to kind of keep it simple, keep it straightforward, talk about a couple things and the expectations of this podcast. These episodes are only going to be like 30 minutes. I want this to be like a drive to work, a drive home from work, a walk with the dog, whatever it may be. I want this to create conversation, discussion. So again, I asked a couple times, a couple different questions, what you guys think of it, what you would do in this situation. So let me know. We'll have a little debrief, as we call it, as nurses do. And we'll talk about a little bit on the next episode, what you guys thought moving forward. So please tune in. This was episode 1. It's been fun. It's been great. Stay tuned for episode 2. We're going to pump out a bunch of these, okay? This is only the pilot. This is number 1 in many. And hey, if you want to be on the podcast, if you're another nurse, physician, whatever discipline in the healthcare system, please reach out to me. I'd be glad to have you, regardless of whatever your opinions are. I'll sit you in this chair and discuss certain topics with you, certain triages as well. So please reach out, feel free. I'm always open to discussion. And again, this is a safe space for nurses to come together. This is the core. This is the foundation. Please create this as a safe space, just like you do in your normal sim lab, right? Everyone goes into sim lab, or when you're going through school and you have these sim labs as well, and you're like, and the professors are always like, this is a safe space. We keep this in the classroom. We don't bring this outside the classroom. That's what this podcast is. This is your sim lab. This is what I want it to be. Keep everything in here. Do your fact checks. Go home. Make sure you're doing things appropriately. Fact check me, and we'll discuss it on the next episode. Please create a safe space for this. I am Anthony. This is Triage.RN. This is the first episode. Thanks for tuning in. We'll see you next time. Over and out.
Red, yellow, green, where do you go? Time is louder than you know. Step by step through the double doors, we decide what matters more. This is Triage.RN.
Podcast disclaimer. The Triage.RN podcast is provided solely for general education, entertainment, and professional discussion purposes. All patients' names, personal details, medical history, symptoms, assessments, test results, treatments, outcomes, and clinical scenarios presented in this podcast are fictional, generated using artificial intelligence. All scenarios are hypothetical. No real patient record, or professional health information is knowingly used or portrayed. Any resemblance to an actual person, patient, healthcare encounter, institution, or event is entirely coincidental. The information discussed on the podcast is general in nature and may be simplified, incomplete, outdated, inaccurate, or unsuitable for a particular situation. It does not represent a complete clinical assessment, an official guideline, an institutional policy, or the application standard of care. This podcast is for discussion purposes only. It is not medical advice, nursing advice, clinical advice, legal advice, regulatory advice, employment advice, or personal advice. Nothing stated, shown, suggested, or discussed during the podcast should be relied upon or used to diagnose, assess, triage, treat, or manage any medical condition, make emergency medical, nursing, clinical, legal, regulatory, employment, or personal, replace an individual patient assessment or professional clinical judgment, determine a healthcare professional scope of practice, replace current legislation, clinical guidelines, professional standards, workplace policies, procedures, protocols, or medical directives, or establish the standard of care for any healthcare professional or organization. Listening to, viewing, downloading, commenting on, or otherwise interacting with the podcast does not create a nurse, patient, clinical, patient, healthcare provider, patient, lawyer, client, consultant, client, or other professional relationship. Listeners should independently verify all information and consult the appropriate qualified professional before acting on anything discussed. Healthcare professionals must follow the laws, professional standards, licensing agreements, scope of practice rules, clinical guidelines, employer policies, procedures, protocols, and medical directives that apply in their own jurisdiction and workplace. Questions concerning professional practice, licensing, employment, discipline, documentation, privacy, or legal liability should be directed to your own lawyer, professional licensing or regulatory body, employer, union, or professional association, and professional liability insurer as applicable. Anyone experiencing a medical emergency should immediately contact your local emergency services or attend the nearest appropriate emergency facility. Do not delay or disregard professional medical care based on anything heard or viewed on this podcast. The views and opinions expressed by hosts and guests are their own. They do not necessarily represent the views, policies, practices, or positions of any hospital, healthcare organization, employer, educational institution, licensing body, professional association, sponsor, or other affiliated organizations. References to medications, products, services, organizations, guidelines, or third-party resources are provided for discussion only and do not constitute approval, endorsement, recommendation, or sponsorship unless expressively stated. Although reasonable efforts may be made to provide reasonable and accurate information, no representation or warranty is made regarding the accuracy, completeness, reliability, usefulness, safety, or currentness of any content. To the fullest extent permitted by applicable law, the podcast creators, owners, hosts, guests, producers, sponsors, distributors, and affiliated parties disclaim responsibility and liability for any injury, harm, loss, damage, claim, cost, or consequence arising directly or indirectly from accessing, relying upon, interpreting, applying, or misusing any podcast content. Use of this podcast and its content is entirely on the listener's own risk. Nothing in this disclaimer is intended to exclude or limit any responsibility or liability that cannot legally be excluded or limited under applicable law. Do not submit, post, email, or otherwise share identifiable patient information, confidential workplace information, or personal health information with the podcast or through its associated social media accounts.